A very good morning, ladies and gentlemen. My name is Shafiq and I'm from Patient Liaison Service Department, Singapore General Hospital. I will be your MC this morning. Thank you for tuning in and welcome to day 1 of 200 minutes of ear, nose, throat health, organized by the Department of Otorhinolaryngology, Head and Neck Surgery. The theme for today will be common ear problems, such as hearing issues and ear infections. So if you have any burning questions for our speakers, do submit them by clicking on the Zoom Q&A button on your screen. So without further ado, let's welcome Associate Professor Cho Song Char, Head and Senior Consultant from the department to give the welcome address and introduction. Prof. Cho, please.
Hi, good morning, everyone. So, Shafiq, can you allow me to turn on my video? Or can you turn on the video for me? Hi, good morning, everyone. Thank you for joining us on this Saturday morning. So, our ENT department is one of the biggest department in Singapore, and we have a whole range of subspecialty, ear, nose, throat, and neck surgery, snoring, and sleep apnea. And this year, SGH celebrates 200 years of founding, and that's why we have this 200 minutes of ear, nose, throat, and health for our specialists to be here to answer some of the questions that you have, and of course to share some of the insights and some of the common conditions that you may be affected. So maybe next slide, please, Shafiq. So as you can see, our department has got 18 specialists, tackling different subspecialty, snoring and sleep apnea, the nose, the ear, the next slide, please. As well as general ENT, voice disorders, as well as head and neck surgery. So today, Dr. Brenda, Dr. Joyce, and Dr. Vanessa will be sharing with you some of the common ear conditions that you may be affected. And please feel free to type into the Q&A if you have any question that you want to ask, and we'll be more than happy to answer those questions. And if you are not able to answer those questions, you want to come and see us, our patient liaison office, just now you have seen some of the QR code. You can either make an appointment with us using the self-referral method, or approach your GP for them to refer to us. So without further ado, maybe we'll get this educational webinar started, and I think you will definitely benefit from the insight and the knowledge that we have to share with you. Shafiq, over to you.
Thank you very much, Prof. Cho, for the welcome address and the introduction of your department. Of course, so let's not delay this any further. And starting with Dr. Brenda Sim, Associate Consultant, the topic that she'll be covering today will be hearing when sound gets blocked. Dr. Brenda Sim, over to you.
Okay, good morning, everyone. Shafiq, could you see my slides?
It's all good, Dr. Sim.
Okay. Good morning, everyone. I'm Dr. Brenda Sim. I'm from the SGH ENT department, and I have a special interest in all diseases related to the ear. And today it brings me great pleasure to talk to you about conditions that can cause hearing loss and what we can do about them. So here's the contents of my talk today. Firstly, we'll talk about how we can hear, and then we'll go through some causes of conductive hearing loss and its management, and then I'll conclude. So, have you ever wondered how we hear? But before that, let's go through some basic anatomy of the ear. As you can see in this picture, there's the outer ear, which comprises of the auricle or the pinna, and the ear canal, in which there's sometimes wax. The middle ear, in which there are 3 small little bones called ossicles. So these are the 3 small bones here, if you can see my pointer. And the inner ear, which has 2 components. One is the hearing organ, which is called the cochlear, which is this snail-like thing. And the balance organ, which is made up of the 3 semicircular canals, as well as the utricle and saccule, which is housed here. So when a sound is made outside of the outer ear, the sound waves or vibrations travel down the ear canal and strike the eardrum, which is here. And the eardrum then vibrates. The vibrations are then passed to the 3 tiny little bones in the middle ear, called the ossicles. And the ossicles amplify the sound, which then gets transmitted to the hearing organ called the cochlea. When the cochlea is activated, it sends signal to the brain through the vestibular cochlear nerve, and then the brain perceives the sound. So this is another picture to illustrate the mechanism of hearing. Again, there's sound waves or sound outside of the external ear, which is then conducted through the ear canal to the tympanic membrane, which is the eardrum. And then the vibrations get passed through these 3 little small bones into the inner ear, which is the cochlea. So the sound from the external environment is conducted through the external ear to the middle ear and presented to the hearing organ called the cochlea. Therefore, if there are any conditions that prevent the conduction of sound waves in the outer ear to the middle ear, it would result in conductive hearing loss. But any abnormalities in the cochlea or along the nerves that sends the signal to the brain would be labeled as sensorineural hearing loss. Can you get the combination of both? Yes, you can, and that would be called a mixed hearing loss. So first, let's take a look at what in the external ear can block sound from getting to the middle ear. Many conditions that result in occupying the space in the ear canal can potentially block sound from getting into the middle ear. Common examples like impacted earwax, foreign body in the ear infection resulting in the ear canal being clogged up by dirty stuff can block sound from getting to the middle ear. And these conditions will be covered by my colleague later on. But let's go through 3 other conditions of the external ear. The first would be medial canal fibrosis. It is a condition whereby the ear canal skin, especially nearer to the eardrum, becomes too thick. And this is often due to chronic ear digging. In the normal ear canal, as you can see in the photo on top, the skin lining should be very thin and the eardrum should be transparent and shiny, as you can see in the top photograph. However, in the case of medial canal fibrosis, due to chronic trauma from, for example, ear digging, the skin thickens and forms a scar tissue. So you can't really see the shiny eardrum in the second photo at the bottom. So you can imagine that sound cannot be conducted as easily through a thick scar compared to if the eardrum was thin and pliable. And this results in reduced hearing. So what can be done? Of course, firstly, you should stop digging the ear. Hearing aids can help to amplify the sound and overcome the thick scar if necessary. Surgery is also another option, and I will touch on this in a while. Growths in the ear canal can also block the passage of sound to the middle ear, but generally speaking, they are not so common. Ear canal osteoma, as you can see in the photo below, is a bony growth in the ear canal. Other than blocking sound to the eardrum, it can also trap wax, which may cause things like infection, or it can also cause the formation of ear canal cholesteatoma, which can erode bone. Surgery can be done to remove the bony growth and widen the ear canal. And again, the surgery is termed canalplasty, which I'll go through a little bit later. Polyps can also arise from the ear canal. So this is a polyp blocking the whole view of the ear canal. And you can imagine that the sound would be blocked as a result. Often it's a result of infection, but more importantly, a cancer needs to be ruled out. And hence, we would often suggest for a biopsy, which can be simply done in clinic. If it is due to infection, generally speaking, ear drops and antibiotics would help. But if it turns out to be cancer or something more serious, then we will counsel, the patient will be counseled for more extensive surgery. So what exactly is canalplasty? It is a removal of disease or unhealthy skin or scar from the ear canal, or even things like removal of the bony growth like osteoma, and widening of the ear canal and laying new skin over. The surgery often can be done through a very small incision, as you can see in the photo on the left, just above the ear canal opening. And new skin is usually harvested from behind the ear, as you can see in this photo. and then laid over the ear canal. The scar is hidden behind the ear and it would not be very obvious at all. Moreover, the wound behind the ear, where the donor site is, tends to heal very well, and in as soon as a few weeks, the wound would already be nicely healed. Often, this surgery can be done as day surgery, and you can go home on the same day. Now, there is also a congenital condition in which you are born with small or malformed external ear. The picture on the slide actually shows varying degrees of severity of this condition called microtia. Often, when the external ear is absent or malformed, the ear canal can also be very narrow or even absent. And the middle ear bones may also be malformed or underdeveloped. So with the lack of normal external ear and absent ear canal, sound can no longer be conducted normally to the inner ear through the middle ear. So the treatment of such patients can be thought of in two aspects. One is the reconstruction of the external ear, either with a prosthesis or using the patient's own rib cartilage. And the other would be, how do we rehabilitate their hearing? So today I will focus more on the hearing aspect. Devices that are suitable for such patients are like the sound arc or the Baha softband. Baha softband is, as you can see in this trial, is generally suitable for babies and young children. And what these devices do is that they bypass the ear canal and middle ear bones to send sounds directly to the inner ear through vibrations to the skull. So the sound processor is usually placed at the bony protrusion behind the ear. This is another example of a bone-anchored hearing device. In a bone-anchored hearing device such as the Baha Connect system, a surgery is done to place the implant and an abutment screw just under the skin and the skull so that the hearing sound processor can be attached to it externally, like you see in this patient. So you can see in the picture on the right that the abutment screw and implant is surgically placed in the area behind the ear. And the patient wears the sound processor externally when the wound is healed. And the sound processor picks up sound vibrations from the environment and are transferred through the abutment to a small titanium implant. The sound vibrations are then sent directly to the bone in the inner ear, which is the cochlear, where they are converted to electrical impulses by tiny hair cells within the cochlea itself. The Baha Attract system is similar, but the surgery is done instead to place an implant with a magnet under the skin. So instead of a screw sticking out of the skin, the skin actually remains intact, and you just simply have to place the external sound processor, which has a magnet component, on the magnet site. So we have gone through conditions in the external ear that can block sound from getting to the inner ear. And this include medial canal fibrosis, in which the ear canal skin and eardrum becomes thickened. We have gone through that growths in the ear canal, such as polyps, bony growths, and tumors, can also block the sound from getting to the middle ear. And also that some people may be born with malformed ears, called microtia and congenital oral atresia, during which there's no normal passage for the sound to get conducted to the inner ear. So let's look at middle ear conditions now. So going back to this picture again, recall that when sound gets presented to the eardrum vibrates, which in turn causes the ossicles to vibrate. And this is how sound energy gets transferred to the cochlea. So any condition that affects the eardrum or the ossicles can cause a conductive hearing loss. Let's look at some of them. Eardrum perforation, middle ear infections, and cholesteatoma are fairly common and will be covered later. But today, let's look at two other conditions called autosclerosis as well as ossicular chain abnormalities. So what is autosclerosis? Autosclerosis is a condition where there's abnormal bone growth within the inner ear. And this most commonly affects the stapes, which is the third bone. And sometimes it can also affect the inner ear. So patient mainly reports hearing loss and tinnitus, and this is due to the fact that the abnormal bone fixes the stapes, resulting in the sound not being able to be conducted to the inner ear. In females, it can be worsened during pregnancy. And some also experience giddiness, especially if the inner ear is affected as well. There's a genetic predisposition for this condition, meaning that it may sometimes run in families. Hearing aids can be used to restore hearing or stapes surgery, in which the abnormal stapes is removed and replaced with a prosthesis so that it is no longer fixed and the ossicular chain can be mobile again. So here's the illustration of the surgery I just explained. Part of the stapes was already removed and replaced with a prosthesis, which is clipped onto the second bone called the incus, and it restores the ossicular chain. So this is the eardrum. Sound gets conducted from the ear canal to the eardrum. And because the ossicular chain is now intact and is now mobile rather than fixed, sound can be transmitted to the inner ear. Now, anything that disrupts the ossicular chain can cause hearing loss. And the ossicular chain can no longer efficiently transmit the sound energy from the eardrum to the hearing organ. So ossicles can be eroded from infection, from cholesteatoma, or it can even be congenitally malformed. So a CT scan is often necessary to diagnose and further evaluate the cause of your conductive hearing loss. And what can be done? Again, hearing aids and surgery. Ossiculoplasty refers to the reconstruction of the middle ear ossicular chain again. There are many types of prostheses available, and the surgeon will discuss with you based on the CT scan findings. Again, often only a very small incision is required, and this is often done as a day surgery case as well. So, middle ear conditions that can block sound include autosclerosis, in which the third ear bone is fixed and no longer can transmit sound from the external ear to the inner ear, as well as ossicular chain abnormalities, which really is an umbrella term to suggest any abnormalities along the ossicular chain, which is these three small little bones in the middle ear. Eardrum perforation, middle ear infection, cholesteatoma are also middle ear conditions that can block sound, but will be covered later in the lecture. So I'll conclude with this slide, and I hope I gave you a better understanding as to how you hear, and also how external ear conditions and middle ear conditions can cause hearing loss. But just a final word to say that hearing rehabilitation is often possible, and treatment is personalized, be it surgical or non-surgical approaches. So with that, I thank you.
Thank you very much, Dr. Sim, for sharing on how hearing and when sound gets blocked. I hope all of you found it very interesting and very fruitful. So if you do have any questions for Dr. Sim, please do submit your questions via the Q&A button that you see on screen. And I'm sure our speakers will be more than happy to address your concerns or questions at all. So let's move on to our next speaker for the day. We have Dr. Joyce Tang, Associate Consultant, who will be sharing with us hearing when the inner ear isn't working so well. She also has a subspecialty in otology and neurotology. Dr. Joyce Tang, please.
Thank you, Shafiq, for your kind introduction. And share screen. Shafiq, can you see my screen and hear me clearly?
Yes, crystal clear.
Thank you. Good morning, everyone. Thanks for joining us this Saturday morning. I'm Dr. Joyce, and I'll be covering about the inner ear hearing loss. So this will be the overview of my talk. I will elaborate more on how the inner ear works and what happens when the inner ear is damaged. And I will also answer questions as to whether inner ear damage is reversible and what to do if there's permanent damage to the inner ear. And this is a very common question I see in the Q&A section. What can we do to prevent inner ear or hearing loss? Okay. Dr. Brenda has already educated us on how the hearing works. Once more, the GIF, sound vibrating the eardrum, vibrating the three middle ear bones called the ossicles, and then these transmit the vibrations to the cochlea. As you can see in the cochlea, there are little hair cells. The hearing organ has hair cells which help us to hear. You see a QR code in my slides. I will have a series of QR codes for slides where I take images or information from other websites which you may find interesting. So you may either scan the QR code or type in the link that's next to it to find out more about the different pictures that I have shown. Moving on. And so in the hair cells in the inner ear, you see the brush-like little hairs. When they are vibrating, they allow ions to enter the inner ear hair cells, which then allows neurotransmitters to activate the nerve cells over here, which then transmit sound signals to the brain. And that is how we hear. From the external ear to the hair cells, to the nerves, and to the brain. And this is a very interesting picture. The picture on this left side here, this shows how neatly organized the hair cells are in a healthy ear. When there is injury to the inner ear, the hair cells quickly become visibly damaged. They become bent out of shape like this. By the way, this is an electron microscopic picture. This is far stronger than any microscope that we use in clinical practice. It's only experimental. None of the MRI scans or CT scans will be able to show you this picture of your inner ear. Sometimes when the damage is more severe, not just the hair cells get bent, but the hair cells themselves die off and get replaced by other kinds of cells like supporting cells. And these supporting cells do not have little hairs, and they are then unable to actually receive sound signals. And that's when you get permanent hearing loss. Harder to image are actually the changes that happen within the nerve itself or even in the brain due to hearing loss. And therefore, I hope I've explained the word sensory neural hearing loss. So sensory refers to the sense organ, which is the cochlear, and neural refers to the nerve transmitting the signals from the cochlear and going to the brain. So you get the term sensory neural hearing loss. This is a very complex system. And as such, when there is someone with sensory neural hearing loss compared to someone with conductive hearing loss, the person who has sensory neural hearing loss often suffers more. Because not just the sound becomes softer, but it actually becomes less clear. It will lack clarity. It will sound a bit noisy. And this is a very common complaint among our patients with presbycusis or age-related hearing loss. They wear a hearing aid and they say, yes, I can hear the sounds, but they're not very clear. And this is the reason why. Because it's not just the inner ear that is damaged, but even the nerves and even the parts of the brain that help us to hear that actually also suffer degeneration. More on that later. So, is sensory neural hearing loss reversible? The good news is, in some cases, it is. Namely, conditions such as temporary threshold shift, sudden sensory neural hearing loss, and some ototoxic medication exposure. So, temporary threshold shift. This is what happens when you go to a rock concert or you're exposed to a loud sound, like perhaps a lot of renovation work, and you may feel like your hearing has dropped, or you may experience tinnitus, which is the sound of or high-pitched buzzing sound. So this dropping in your hearing will naturally recover to normal or baseline over hours or up to 30 days after the noise exposure. Of course, if there is a very severe damage, like for example a loud bomb explosion, and there is a large drop in your hearing of more than 50 decibels, then there is unlikely to be full recovery. Historically, temporary threshold shift was thought to be a mechanical disruption of those hair cells, like we saw in the previous electron microscopic picture, due to this high-energy fluid wave that gets passed through. And they saw that after a while, these hair cells will then straighten out again and you'll be able to hear normally. But some newer studies actually show that firstly, it's not just the hairs and the hair cells that are damaged, but sometimes even the supporting cells around them or even the nerve endings to undergo changes. And therefore, although the hearing may appear to recover if we do a hearing test, but there may be some loss of clarity. And subsequently, the ear is also more prone to developing hearing loss at an earlier age. So yes, although hearing loss after a loud concert is likely to be temporary, if there's too much repetitive damage, too much injury, it may not recover fully, and you may be placing yourself at unnecessary risk of later hearing loss. The next condition, which is potentially reversible, is sudden sensory neural hearing loss. This is an unexplained rapid loss of your hearing over at most 3 days. This is not due to a blockage in the hearing, such as whenever a wax accumulated or an external ear infection. This is a drop in the sensory neural hearing, so the inner ear or the nerve is affected. This is an emergency. Please see a doctor immediately. This can be your family doctor, the polyclinic doctor, or even the A&E if these are not available, for example, during a public holiday. This is so that you can get treatment as soon as possible. That's because early treatment has been shown to improve the chances of recovery of your hearing. Also, you will need a referral to ask ENT for further assessment of why you have hearing loss. Thankfully, 30 to 60% of patients may recover spontaneously, which means without any treatment at all. And this usually happens within the first 2 weeks. Recovery beyond 3 months is rare. Numerous studies have been done to see what is the best treatment for recovering hearing loss after sudden sensory neural hearing loss. And most studies agree that giving oral steroids as soon as possible gives the best chance of full recovery. Some studies quote as high as 85% rate of recovery if steroids are given within the first week. Alternative treatments that cannot be given by a family doctor and that definitely require specialist care by the ENT include intratympanic steroid injections, which is to use a very fine needle to go through the eardrum to instill liquid steroids into the middle ear. Another therapy that is recommended is hyperbaric oxygen therapy. Here in SGH, we have a hyperbaric and diving medicine center, which provides hyperbaric oxygen therapy for sudden sensory neural hearing loss after appropriate consultation and evaluation of suitability. And next condition, which really potentially reversible, is that of ototoxicity. Auto refers to the ear, and toxicity refers to like a poison or a damaging chemical. So after ototoxic exposure, some of the symptoms may include tinnitus, once more, that's the term for the sound, or hearing loss and dizziness. And these usually occur shortly after the medication has been given. There are more than 600 medications that can be ototoxic. The common ones that we see in our practice would be that of chemotherapy, certain antibiotics, and certain heart medications, or even painkillers like NSAIDs. Of course, for medications that there are alternatives, you should choose an alternative that does not cause any hearing problems. Sometimes you may have if you develop an uncommon side effect like hearing loss, you may switch to a different medication. However, for some patients who don't have much choice, for example, if the person has cancer and requires a particular chemotherapy for appropriate treatment, then sometimes the doctor has no choice, and there is a discussion whether to choose that particular chemotherapy drug and risk hearing loss, which is probably warranted, as opposed to choosing another medication which may not treat the cancer so well. Some patients also have very serious infections that the bacteria are very resistant to less damaging antibiotics. And once more, these patients also have not very much choice but to risk their hearing to get these medications. That is where we come in. Monitoring their hearing during therapy with such ototoxic medications is key. Early detection of hearing loss can prompt a discussion of maybe dose adjustment, change of medications, if the patient experiences ototoxicity with these medications. So, unfortunately, sometimes the hearing loss is not reversible. And actually, the most common cause of permanent sensory neural hearing loss is neither temporary threshold shift, nor is it ototoxicity, nor is it sudden sensory neural hearing loss, but presbyopiosis. That is a condition of age-related hearing loss. Unfortunately, there is no medication for presbyopiosis or permanent sensory neural hearing loss. Instead, we will recommend hearing aids. And for patients who cannot even hear well with hearing aids, we will recommend surgery, such as a cochlear implant. This is my patient, and I recently saw I took a photograph. He has agreed to use this photograph for this forum. I wonder if you can see anything special about him. Let me go on to the next picture. How about now? Do you see anything special? Finally, you can see that actually my patient is wearing a hearing aid. But you can see that this hearing aid is very discreet and almost invisible. There is this little thin wire that goes into the ear, and if any casual observer looks at him, you really cannot see that he's wearing hearing aids. And he has very short hair.
Sorry, Joyce, to interrupt for a little bit. I think you may have to adjust your audio a little bit because I think there's some comments that it's a bit difficult to hear your audio.
Okay.
You want to use your computer mic straight away rather than the earphones?
Okay, sure.
Sorry, everyone, for the slight delay. I think it's just better for everyone to hear better, especially since there's an ENT talk, and then we can continue from there.
Is it clearer now?
Can you continue speaking? Then we'll let you know in a little bit.
So this patient was also wearing hearing aids, and you can see once more that it is very discreet and you cannot actually see the hearing aid, even though this lady has very short hair as well.
Yes, it's much better. Thank you.
Thank you. Other photographs as courtesy of the hearing center. These hearing aids have slightly thicker wires, but they are also very transparent and fairly invisible, even for patients who have short hair. Sorry about the audio issues. Okay, so I'll bring you back to this picture which I showed earlier. So one of the most common complaints we have is, Doc, I wear a hearing aid now and all the sounds are louder, but it just sounds very noisy. And that is because of the sensory neural, the neural component of the hearing loss. So unfortunately, with time, the nerves are degenerating, as well as the brain parts of the hearing are also degenerated due to prolonged lack of sound stimulation. Therefore, with hearing aids, it's recommended that you wear hearing aids for at least 8 hours every day, except when you need to shower, or when you need to sleep, or when you need to swim. The 3 S's. Sleep, shower, and swim. This is because you need to retrain your brain and your nerves to hear clearly again. So the one that I showed, the model of the hearing aid, is what we call the behind-the-ear hearing aid with a receiver and the canal hearing aid. There are many brands and forms and types of hearing aids, such as those in-the-ear hearing aids, in-the-canal hearing aids, and completely in-the-canal hearing aids. Many patients come in and they ask for the smallest possible hearing aid because they feel that they will be the most invisible. However, some of our patients request for the small hearing aids, and their fingers that already have a little bit of age-related damage as well, and they are unable to handle the very small hearing aids properly. Also, for patients who have very severe hearing loss, these small hearing aids are less suitable. How do hearing aids work? There is a microphone externally which picks up the sound in the environment, and the hearing aid then customizes and adjusts and amplifies or makes the sound louder, and it then goes to the speaker, which is in the right ear. If there is a lot of amplification to be done, then the sound from the speaker is very loud, and sometimes the sound from the speaker goes to the microphone, and you get feedback, which is the loud sound, which is very uncomfortable, and also audible to bystanders. Therefore, in patients who need a lot of amplification because they have severe hearing loss. We usually recommend behind the ear hearing aids. As you have seen though, even though they may be behind the ear, they are actually still very discreet. Now, for patients who cannot hear even with the best and strongest hearing aids, we recommend cochlear implants. Cochlear implants have been around since the 1950s when they were first invented, and they have come a long way since then, with many innovations and many improvements in the cochlear implants. They have helped numerous babies who are born deaf hear and speak normally and attend mainstream school and function like normal hearing individuals. Individuals with normal hearing. And increasingly, we are also implanting patients who may have lost their hearing from other reasons, not just congenital hearing loss, but also age-related hearing loss or other forms of hearing loss. So how does the cochlear implant work? Like the normal hearing aid, we have a microphone, and this microphone is connected to a processing device which changes the sound to electrical signals, which are then transmitted through the wire into a transmitting coil. As you can see here or in this picture, the speaker is around behind the ear, as like a behind the ear hearing aid, and transmits the electrical signals to the transmitting coil over here. Some models actually combine the speaker with the transmitting coil, so all you have is just one unit, which is a single round disc that you place over the scalp. This is connected through a magnet to the internal component, which is this area here, and over here on this GIF. So the magnet then receives the signals and converts it back to electrical signals, which are then transmitted along the electrode, the wire, into this component that we insert at this round into the cochlear. Once more, look at the GIF. This is how the signals are transmitted. And it goes then, stimulates the cochlear nerve directly, and that's how we hear. And last part of my talk, how do we prevent inner ear damage? Inner ear damage is caused by oxidative stress in the inner ear. So a diet rich in antioxidants, bright, colorful fruits and vegetables have lots of antioxidants. Supplements that have been shown to be good for hearing loss or for your hearing pathways are omega-3 fatty acids, vitamins A, C, E, folic acid, and minerals such as magnesium, zinc, and iodine. Exercise is important too. If you have a BMI that is higher than 25, you will be considered overweight and at risk of developing hearing loss. How does being overweight cause hearing loss? It's postulated that it's due to damage due to low oxygen levels and production of free radicals from fat cells. Also, there is reduced production of adiponectin, which has anti-inflammatory effects. So exercise helps you lose weight and can help prevent hearing loss. Not just that, cardiovascular health, which comes from jogging and running and swimming, this has been linked to better hearing in many studies as well. Now, even certain yoga poses, like the one I show in this picture here, that are supposed to be beneficial for hearing as well. Next, smoking has been found to be a significant risk factor for hearing loss in epidemiological studies. Alcohol is a known ototoxic chemical. It is poisonous to the inner ear in high concentrations. Therefore, binge drinking is definitely not recommended. The evidence for light to moderate alcohol consumption is more conflicting. There is no clear evidence that light to moderate alcohol consumption is linked to hearing loss, although chronic alcoholism is also linked to hearing loss. Next, sleep, very important for overall wellness. Insomnia has been linked to hearing loss, and especially severe sleep apnea has also been shown to be associated with more than 30% increased risk of hearing loss. This is also to advertise for the upcoming ENT talk that we are giving another day on sleep as well. And not just rest for the body, but rest for the ear as well. If you find yourself in a series of Zoom meetings or listening to music while studying, do remember to give your ears a break, take off your earphones, and just let it rest for a short while every hour or so. Next, control of pre-existing medical conditions. Diabetes, hypertension, high cholesterol, these clog up your blood vessels, which then affects blood flow. Lack of blood flow to the inner ear will be also linked with hearing loss. Therefore, it is important to control these medical conditions. If you have no medical conditions, remember to go for regular screening to ensure that you control and pick up any medical conditions. Next, reduction in noise-induced damage is extremely important. With children now undergoing many hours of Zoom for school, it's important, especially for children, that you get them earphones or headphones. They have safe limits. Usually headphones for children have a maximum volume of up to 75 to 85 decibels. So this is a safeguard for children. For those who are exposed to loud sounds at work, always wear your hearing protective equipment if they are provided. There are also smartphone apps now that you can download at the Play Store that help you monitor your own sound exposure to your device as well as external environment. So, the 2010 Singapore National Health Survey results actually show that 12.7% of young adults from 18 to 29 years old have at least mild hearing loss in at least 3 of these frequencies tested in at least 1 year. So actually, hearing loss is much more common than you think. And for occupational exposure, for work-related exposure, it is hazardous to listen to 85 decibels and louder for more than 8 hours a day. And every time the amount of sound is increased by 3 decibels, then the amount of permissible exposure time decreases by half. And actually, occupational noise exposure limits are the bare minimum standards that you need to aim for. Firstly, even if you adhere closely to these standards, 8% of people may still develop noise-induced hearing loss. That's because some people are more sensitive to noise damage because of genes, for example. Therefore, for recreational exposure to sound and noise, we should go by much lower limits. WHO actually advocates for less than 80 decibels over 40 hours a week for adults and 40 hours and 75 decibels over 40 hours a week for children. It is less than 6 hours of listening a day. Alternatively, an easier rule to remember is 60-60. 60% of maximum output of your personal audio device over 60 minutes a day. That would be a very safe limit. Personal audio devices usually have output between maximum output of 75 decibels to 120 decibels. So you do need to take note of your own exposure to these audio devices. In a Singaporean study in 2014 of 2,000 students of a tertiary institute, we found that 16% of participants listening to the music were actually hearing it at more than 85 decibels for more than 8 hours, putting them at risk for permanent noise-induced damage. So what types of earphones are better? At any given sound intensity or sound loudness, if you wear a headphone, the sound is produced outside the ear. If you wear an in-the-canal earphone, the sound is that much closer to your eardrum. You can actually deliver up to 9 decibels louder sounds than a headphone. Something to keep in mind. Also, we recommend noise cancellation earphones or headphones because these reduce ambient noise and allowing one to enjoy listening at softer volumes. This is especially important if you listen to music or watch videos in a train, for example, and it's underground and it's very noisy. Once more, a reminder when purchasing headphones for children to buy those with volume limiters so they are programmed to stay below 75 to 85 decibels. Over here, I have a few more links that you can follow through to learn more about your hearing and about hearing aids. If you have any questions later. And on to Dr. Vanessa Tan.
Thank you very much, Dr. Tang. And that was hearing when the inner ear isn't working so well. Okay. Dear participants, we have noted the audio issue, and we do seek your kind understanding that our speakers are all working from home and have worked very hard to put together this event for you. So we have noted your feedback, and we will ensure that the audio is better checked for future events as well. So do bear with us. Just ensure that your volumes are up, and if you have your earpiece, please put that on, as it can help isolate the sound as well. Okay. So moving on, the next speaker is Dr. Vanessa Tan, and she is a consultant at the Singapore General Hospital, and she graduated from NUS School of Medicine in 2007 and has been an ENT specialist since 2018. She was awarded 2 MOH scholarships, the first Masters in Clinical Investigation and the second for specialty training in ear surgery in Melbourne. Today, she'll be talking about simple but common ear condition, ear infections, and how to prevent them. Dr. Tan, please.
Okay, thanks, Shafiq. Good morning. I hope you can see my video. Are you able to see it, Shafiq?
Dr. Tan, we'll need you to share your screen.
Yeah, but can you see my face?
Yes, you can see it.
Okay, great. So let me share my screen. Indeed, yeah, nowadays a lot of us are working from home, and I had to send my children off to a Chinese class to make sure there's peace in the house. Let me just start my slideshow. Okay. So you can see my presentation?
That's right, Dr. Tan. All good.
Okay, thank you. And I hope you can hear me clearly, so feel free to stop me at any time if the audio is not good. So good morning. Thanks, Shafiq, for the very kind introduction. It's been almost an hour of screen time, so all of you, if you need to have a little stretch of your neck and your arms, please feel free to do so. And thanks for taking time on a Saturday to tune in. I'm Vanessa. I'm a consultant ENT surgeon at SGH, and today I'm going to talk about one of the very common ear conditions that I see, ear infections, and how to prevent them. In fact, when I was a medical student, my mom, she felt such joy when the ENT surgeon unblocked her infected ear by suctioning away the pus that my mom told me, go and do ENT. And so I listened to my mom, and here I am today. Today, I will be covering 3 broad topics. The first, and I see it's a very hot topic because there are so many questions about this on the Q&A board. The first will be about earwax. The second will be on ear canal infections, and the last will be on a hole in the eardrums. So this was the hot question on our Q&A board, and very frequently, every day, there's bound to be a patient who asks me, how do I clean my ears? So they'll ask me, oh, Dr. Tan, can I stick a cotton bud to clean my ears? And before I answer that question, let me just get my laser pointer out. Before I answer that question, let's just talk about how earwax is formed and its purpose. So earwax is produced by glands in the outer 1/3 of the ear canal. So you can see on my laser pointer that the outer 1/3 of the ear canal is what we call the cartilaginous ear canal. It's a soft part of the ear canal. And that's where the oil-forming glands are located. The inner 2/3 of the ear canal is the bony ear canal, and here you don't have any wax being formed. So wax has its reasons for being there. It is antibacterial and antifungal. And as the skin of the ear canal grows outwards, it actually carries the wax out like a travelator. So with regards to using cotton buds for the ear canal is too small and the cotton bud is too big. So very often we see patients pushing the earwax towards the eardrum further in. So whenever I see patients with earwax in the bony part of the ear canal, then I know that they've been likely digging their ears. To allow you to appreciate what an abnormal ear is, I'll first like to share with you what a healthy looking ear looks like. So this is a picture of one of my patients with a very good healthy looking ear. And you can see that the bony ear canal here is nice and pink, it's dry, and the eardrum here, this grayish round thing is complete and it's intact, and you can see a healthy cone of light here. So this is a perfect eardrum. In contrast, this is an ear with a fungal infection. And this is a patient that I treated. You can see that the ear canal here is narrowed, and you can see this white fluffy material. This is fungus. It's very characteristic. You can see these strands of spores. And in the middle of the picture, you can see the culprit of the fungal ear infection, and the culprit is the cotton bud. So often patients are not even aware that the cotton buds have been stuck inside their ear. And the record number of cotton buds I've taken out of one patient, you want to make a guess, is it's actually 6 cotton buds from one patient, 3 from each ear. And the patients are often very cute. It's quite often the elderly ama and uncle that you say at the end, when I show them the cotton bud, they'll give me a very surprised stare and say, oh, how did the cotton bud get there? So, of note, I've seen a very severe case of ear infection due to a cotton bud, and the ear infection was so terrible that the patient had a collection of pus in the face and the neck. In fact, we couldn't even see the cotton bud, which was the culprit, because the swelling was so severe. After we treated with antibiotics and drained the pus, then we could see the culprit cotton bud sitting behind all that swelling. So cotton buds can cause quite a lot of damage. So once again, the picture on the left here is a normal looking eardrum, and this is a picture of my patient after I removed the cotton bud. And you can see that the eardrum here looks a little bit swollen and red, and I am a little bit concerned that this area will not heal and there will be a hole in the eardrum. So another common question I get about how to remove earwax is, how about ear candling? Is it safe? And I would say that ear candling is not safe, because I've seen a case whereby the eardrum got scorched from ear candling. The eardrum is thinner than paper, and it got melted away by the heat from the candle. So my advice is a absolute no to ear candling. Don't let your ears play with fire. But another question that also popped on the Q&A board is that, but my ears are so itchy, Dr. Tan, what can I do? I really want to put something in to scratch it. And I know itch is a very difficult sensation to withhold. And I usually tell patients to rub the ear from the outside. And if the ears are really terribly itchy, sometimes because of eczema of the ear canal, then you can use some olive oil ear drops to moisturize the ear canal. Or you can also use some steroid ear drops. Steroid ear drops will kind of break the eczema process, and hopefully when the skin is less irritated, the ear itch will go away. But try not to dig your ears, because you push your wax further in and you can cause infections. So this is a very interesting condition of abnormal earwax. It's not common. It's called keratosis obturans. So once again, this is a picture of my patient. I've been collecting a lot of photos from my patients for this talk, and you can see at the top, this is a normal ear canal, and at the bottom you can see this huge piece of wax. So the interesting thing about keratosis obturans is that the wax tends to cling to the ear canal, and it can be quite difficult to remove. This earwax does not self-clean. We don't really know what the cause of this is, why some patients get such terrible earwax, but it's not common. So the problem with keratosis obturans is that it also expands the ear canal. It actually widens the ear canal. So you can see that this picture I've just shown is after I've removed the earwax. You can appreciate that the ear canal floor has been lowered and the ear canal has been widened. So these patients with keratosis obturans do need to come and see us periodically to have their earwax cleaned by ENT specialists. Otherwise, most of the time, earwax can be managed quite simply by using certain agents to soften the earwax. You can use water, saline, or oil-based ear drops. Not one is proven to be superior over the other. And many GPs would be happy to clear the earwax by flushing the ears with saline or water. This is called irrigation. And the risk of irrigation to flush out the earwax is generally very low. The two main risks would be a hole in the eardrum. The risk is less than 1%. And the second risk is vertigo. Vertigo is a giddiness whereby the world feels like it's spinning. You feel like you're in a roller coaster, but actually nothing around you is moving. So vertigo is a very uncomfortable sensation, and this usually happens due to the the temperature of the saline that is used to irrigate the ear. Because when the temperature of the saline is too cold, then it is not that of body temperature. It can actually cause inner ear irritation and giddiness. So when the wax is too impacted, the GP can then refer the case to us, to ENT, and we will remove the earwax with a microscope and special instruments. Because the ear canal is pretty narrow, you do need special instruments to clean out the earwax, and the microscope is definitely very useful because you can see, I can see what I'm doing. So I definitely still enjoy that instant gratification of giving patients instant hearing improvement in their hearing and blocked ears by cleaning the earwax. So I hope from what I've just mentioned that you have learned and can also educate your family and friends that earwax not causing symptoms or blocking your ear canals should be left alone. I think I saw a question about like someone saying that their child has a lot of earwax. So quite often in the kid, when you see the earwax, it's almost coming out already. So try to leave it alone, and then it will just drop out on its own. And don't over clean the ears because earwax has its function. And there's no need to use daily olive oil unless the GP tells you that your earwax is very hard and impacted, and the olive oil is to soften the earwax. So the second broad topic I'll be covering is ear canal infections. So you can see from these two pictures that the ears are very abnormal, but somewhat different. So the picture on the left here, you can see that the ear canal is narrow, it is red. You can see some yellowish discharge, you can't really see a nice eardrum. So this is quite typical of bacterial ear infection, which tends to be more common than its counterpart on the right. So the counterpart on the right is a fungal ear infection, and you can see these black spores. And usually a fungal ear infection is quite itchy, and sometimes it follows on after a bacterial infection. And these are the two most common bugs that cause ear infection. They're treated slightly differently with different types of ear drops. So some predisposing factors for patients who keep getting ear infections, if they are frequent ear diggers, if they use hearing aids, and I think our warm tropical climate in Singapore also predisposes us to ear infections, or if there's frequent swimming like in the open sea. So for the treatment of ear canal infections, not infrequently, patients ask me for oral antibiotics for their ear infection because they feel that perhaps oral antibiotics is better than ear drops. But ear drops are actually better than oral antibiotics in treating ear canal infections. And the reason is because antibiotic ear drops are 100 to 1,000 times higher concentration in the ear than what oral antibiotics can reach. So most of the time we would start patient on antibiotic ear drops if it doesn't have that typical spores appearance that you saw in the previous picture. If you see spores, if I see spores, I will start a patient on antifungal ear drops. And to note, antifungal ear drops can be a little bit stinging. So I do warn my patients that they have to bear with a little bit of pain, and when the infection settles, it will be okay. Generally, the ear drops needs to use for at least 1 week, if not 14 days. And sometimes when there's so much pus in the ear, I would need to see the patient more frequently to clean up the pus so that the antibiotic ear drops can work better. Also, very importantly, something that's easy for patients to do is to keep the ear dry. So if you're using hearing aids, stop wearing them because the ear infection can also spoil the hearing aids. And whilst bathing, you can keep your ears dry by using some cotton wool. I'm giving a talk. Sorry about it. So you can use some cotton wool to keep the ears dry. And lastly, you can also use a hair dryer on the lower setting to dry the ears after a shower. Let me pause for a little bit. Yeah, just have to settle my son for a little bit. Give me a sec.
Dear participants, just bear with us for a moment. Just to address some of the concerns, yes, this webinar or this public forum is being recorded and it will be uploaded onto our SGH YouTube page where we do already have a current playlist of all our past webinars as well. So if you have not gotten a chance to take a look at it, we will drop the link for you below in the comment section, and you can take a look at our past webinars and see the various departments that we have collaborated with this year itself. And of course, at the same time, this event is live on Facebook stream if you want to have an immediate view of the event itself. Thank you very much for your patience, and of course, we seek your kind understanding.
So sorry about that. I thought my son was at Chinese class already, but I apologize for that. Okay, so in terms of some practical instructions on how to administer the ear drops, firstly, I would advise someone else to drop the ear drops in for you so that you know that's definitely going into the ear canal. And fill the ear canal with ear drops, and do lie the affected ear up for at least 5 minutes so that you ensure that the ear drops enter the ear canal. And also, something simple to do is just to massage your eardrops in. So you can either pull your ear forward and backward, or you can just press this part of the ear to massage your eardrops in. Okay, next, in terms of ear canal infections, there can be some mimickers. So a mimicker is something that's pretending to be an ear infection. So neomycin is an antibiotic ear drop which on prolonged use can cause patients to have allergic reaction where the skin is weepy and sheds like dandruff. And once you stop the neomycin ear drops, this will stop the problem. Herpes zoster oticus is chickenpox or shingles of the ear, and the pain may come on before the typical blisters that you see here. So these are the typical blisters that you see in herpes zoster oticus or chickenpox of the ears. And when patients have this kind of rash in the ear and also have one-sided facial weakness, then we call this Ramsay-Hunt syndrome. So Ramsay-Hunt syndrome happens also due to a viral infection. And you can see in this picture, the man has a red eye because he's unable to close his eye fully. He's unable to smile symmetrically. The right side of his lip is drooping. And in fact, this condition can be also associated with giddiness and hearing loss. So this condition requires antiviral and steroid medication. So ear canal cholesteatoma is trapped skin in the ear canal. The trapped skin will erode the ear canal and cause infection. And this condition requires surgery. So the last condition, ear canal cancer, is rare, but whenever I see an unhealthy area of ear canal skin, which is persistent despite of treatment, I will take a biopsy to ensure that it is not cancer. Sometimes we also see ear pain that is not due to an ear problem, but is due to referred pain from nearby structures. The ear is very sensate and shares the same nerves as many nearby structures. So hence, issues with nearby structures such as the jaw, the teeth, and head and neck cancers can be referred to the ear. I think just now there were some questions about ear pain, whether it was associated with lymph nodes in the neck. Yeah, so it is possible that sometimes like a cancer hiding in somewhere like the tongue can be referred to the ear. Maybe to give a simpler analogy, like a patient with a fishbone in the throat, they may not only feel pain in the throat, but they also may feel pain in the ear. And this is because the nerves of the ear are similar to the nerves that supply the nearby structures. So this is called referred pain. So if a patient complains of ear pain and the ear looks normal, I will need to do a complete ENT examination to make sure that the teeth are healthy and there's no cancer hiding in the head and neck region. So a complete ENT examination would involve putting a scope into the nose. This is a painless procedure. I'm sure nowadays we are very familiar with things being poked into our nose. So we are more or less been accustomed to such an exam, and it's done at the same seating when you come and see us. It's a quick examination, it only takes about 5 minutes or less. So when ear pain does not get better and the patient has underlying conditions such as diabetes, which impairs the immune system, I get worried about malignant otitis externa. In the past, before antibiotics came along, patients had a 50% risk of dying from this condition. And this is due to an uncontrolled ear infection, which has spread to the bone. So this is the most severe type of ear infection, and patients have severe ear pain, often affecting their sleep. And they need to pop Panadol like round the clock. The pain is still persistent. So when I see a diabetic patient with ear pain that's not responding to ear drops, and the pain has persisted more than 2 to 3 weeks, I do get quite worried, and I'll need to take some samples of the pus in the ear to send it to the lab to see what kind of bacteria is growing. So the issue with malignant otitis externa is that it can also affect the nerves exiting the brain and can cause conditions that cause facial weakness. So this condition requires a hospitalization and long-term antibiotics, and usually the patients need to stay in the hospital for 2 to 4 weeks and go home with outpatient antibiotics. They need a total duration of antibiotic treatment for 6 weeks, and you work with the infectious disease control doctor to control the infection, and also the diabetic doctor to control the diabetes. So thankfully, with regular ear cleaning, strict diabetic control, and antibiotics, the mortality from this condition has fallen drastically. So the last topic I'm going to talk about is the hole in the eardrum. So the first cause of a hole in the eardrum can be due to trauma. So it can happen from a slap, like a very passionate kiss, from diving, loud sounds, and ear digging. Not infrequently, I've seen parents bringing their children, saying that digging the child's ear and somebody knocked their hand and caused the eardrum to be perforated. So this picture on the right is a picture from my patient, and he was punched by a friend, and he had sudden ear pain, bleeding, and hearing loss. And you can see there's a hole in the eardrum here. So the good news about these traumatic eardrum perforations is that more than 90% of them heal spontaneously, and especially children, they heal well. And the healing is quick. It usually heals in 2 to 8 weeks. So in comparison, a traumatic ear perforation is something that happens acutely and heals well. But in comparison, there's also what we call chronic perforations, like the one here. And this happens because of repeated ear infections. So the problem with this chronic ear perforations or hole in the eardrum is that whenever water gets into the ear, the patient will have ear discharge and complain of pain, yellowish ear discharge. So this infected perforation or hole in the eardrum can be managed by the GP. Similarly, ear drops are better than oral antibiotics for such conditions. And if the infections are very frequent, then the GP can refer to ENT for consideration of a small surgery to patch the eardrum. So a very important question when we see a patient with a hole in the eardrum is, how often is your ear wet? So if it's wet frequent enough to cause you change in your quality of life, because you always have to see the doctor, you can't do your usual activity, like you can't bathe without having to block out your ear, then I think surgery is a good option to patch your eardrum. So this picture shows a fairly large hole in the eardrum, and in fact, I can see the hearing bones in the middle here. So holes of the eardrum come in a variety of sizes and severity. So this next picture shows a smaller hole, and you can see there's this white calcific plaques on the eardrum, and this is usually a sign of previous ear infection, and after the infection, when the eardrum heals, it forms this scarring. So this is another hole of the eardrum. I'm just outlining the hole, and this hole is much more worrisome than the prior two, and because in this one you can see there's trapped skin in the middle ear. So medically, we call this a cholesteatoma, this trapped skin, and we are concerned about this trapped skin expanding in the middle ear and causing problems with infection or eating into structures in the ear, causing worsening of hearing, or even going outwards towards the brain or going inwards towards the hearing organs and balance organs. So whenever we see patients with all these trapped skin, we need to do surgery to prevent complications. So the surgery to patch an eardrum is easy. It's a day surgery. General anesthetic is 1 to 2 hours, and the success of an eardrum closure is more than 90%. So there are various routes that you can approach the eardrum surgery. So you can make a little cut behind the ear, and you can see the cut usually heals very well and it's not obvious at all. For smaller holes, we can go through the ear canal, so there's no external scars at all. So the incision or the cut that we create really depends on the nature of the hole. So I'm just going to show a very short video of a patient I operated on, and this surgery of myringoplasty is the surgery of patching an eardrum, and endoscopic means we use a telescope and put it into the ear canal, and you can see that this patient has a eardrum in this portion of the ear, and usually we actually have to freshen the edges of the hole in order for it to heal well. And as I mentioned, sometimes it's associated with abnormal skin in the ear, so that patient, they have a collection of abnormal skin in the ear. So I'm now raising the skin of the ear canal, and the skin of the ear canal is the thinnest skin in the entire body, so I really have to be very gentle when I raise the skin in order not to tear it. And you can see the nice white bone underneath, and this is the skin that's being raised up. And now I've raised the skin and entered the middle ear, and you can see this white tissue that is abnormal. That's the abnormal skin that is trapped in the middle ear, and that needs to be removed in order to prevent complications such as infection, pain, worsening hearing, and to make sure that this doesn't continue to eat away critical structures in the ear. So nowadays, with the invention of endoscopes, the visualization is very good. Traditionally, ear surgeons like myself, we are very comfortable using the microscope, but now we have a new toy called the endoscope. So now you have a perfect view of the hearing bones here. So this is the first hearing bone, it's called the malleus. This is the second hearing bone, it's called the incus. And this is the smallest bone in the entire body, it's called the stapes. And you can see that the hearing bones are moving well. I have to remove this malleus bone partially due to some skin that is stuck on it. And the next part, I'm actually going to take some tissue underneath the skin to patch the eardrum. So this is actually some new tissue that has been used to patch the eardrum. So I'm just placing the graft. The graft is what we use to repair the hole. I'm just placing it well. And the healing after the surgery is pretty quick. It only takes about 1 to 2 months. But actually, the day of the surgery, patients feel quite normal. Okay, so this picture is 2 months after surgery. You can see now there's no hole, and it's almost like a normal looking eardrum. So the healing is fairly quick. So I think 3 learning points I have from my talk today is 1, try not to dig your ears. Trust that your earwax will come out on its own. Secondly, is that ear drops are the best for ear infections, and it's better than oral antibiotics. And thirdly, if your ear continues to be problematic in spite of seeing a GP, do feel free to come and see me. So I'll just cover a bit of my special interests in ear, which I've not talked about. And my 2 main interests lie in acoustic neuromas. This is an inner ear tumor which I work closely with my neurosurgery partners. And there are various ways that we manage it depending on the size of the tumor and the age of the patient. And I'm very proud to say that we have a very good service here in Singapore General Hospital. The second interest of mine is in pediatric hearing loss. I was unable to put up pictures of my patients, but these are pictures of my children, Zach and Ellie. And I love seeing children. They bring such joy to me in clinic. And I'm very proud to say that the Hearing Centre in SGH is the biggest in Singapore. We have a very dedicated team to improve hearing for our patients. We have 13 audiologists, 3 auditory verbal therapists, and 6 ear surgeons. So together, we want to improve the hearing for all our patients. So I've come to the end of my talk. Thank you.
Thank you very much, Dr. Tan, for your sharing on ear infections and how you can prevent them. Okay, now that all 3 of our speakers have presented their respective parts and we've received many questions submitted, and of course, it's time for us to go on to the Q&A segment. So of course, now I'd like to invite all the speakers to turn on their cameras, and of course, we'll have the Dr. Joyce Tang, who will be assisting to moderate the segment itself.
Okay. Is there any problems with my audio now?
Much better, Dr. Tang. Thank you very much.
Okay. To let me know if my audio goes off. Okay, this first question, is it a concern if my ears are blocked frequently? Dr. Tan, do you mind answering this question, please?
So this is also one of the most common conditions that we see, a blocked ear in our clinic. And there's a variety of conditions that can cause it. So anything from problems in the ear canal, like earwax, a foreign body can cause it. Even problems with the eardrum, like a hole in the eardrum, can affect the hearing and cause you to have a feeling that ear is blocked. Inner ear problems, such as eustachian tube problems. So quite often, patients with eustachian tube problems may have had a prior flu that caused the eustachian tube to be swollen. So the eustachian tube is a pressure equalization tube that connects the middle ear to the back of the nose. So when patients complain of a blocked ear, I would do a nasal endoscope. I'll put a scope in through the nose just to make sure that the other end of the opening of the eustachian tube of the nose is patent and we don't miss something like a nose cancer, which is one of the most common head and neck cancers in Singapore. So obviously when I see a patient with a blocked ear, I'll first examine the ear and I also do a nasal endoscope just to check. So one of the most frequent diagnoses is eustachian tube dysfunction. Unfortunately, eustachian tube dysfunction is quite a difficult symptom condition to treat, and there have been a variety of medications that have been proposed to help this, such as using nasal sprays, antihistamines, even steroids, but in terms of medical research, none has been found to be superior. There are certain procedures that have been advocated, such as putting in a balloon to dilate the eustachian tube, or even making a little cut on the eardrum to put a ventilation tube. But I think the success of these procedures is also quite variable, and it really depends on how affected the patients are by their symptom. If they are not too affected, I generally reassure them and re-evaluate them in a few months' time. If they are extremely bothered by their symptom, then I may offer some procedure for their ear. I hope that answers the question.
Sounds good, Dr. Tan. The next question we have is, how common is age-related hearing loss and what causes age-related hearing loss? I'll take this question. Hopefully I'm quite clear. So it's difficult to know the exact prevalence, but based on Singapore research studies, there was one paper that was published in 2017, which did a survey in St. Luke's Hospital and Community Hospital. We found that in patients above 60 years old, up to 50% had hearing loss already. And in patients above 80 years old, 90+% had hearing loss. Age actually does not cause hearing loss, but it does allow you to accumulate injury and damage to the inner ear, causing hearing loss. This injury can be from chronic medical conditions such as diabetes, hypertension, cholesterol, and accumulated noise injury to the inner ear. Hope this answers your question. Next question. There are many questions in the chat group about tinnitus. I'll view this question as well. Tinnitus is a sound which one person can hear, but no one else can hear. Commonly, this is due to inner ear issues. It can be due to hearing loss. It can happen after surgery as well. And sometimes it gets better once the hearing loss resolves, for example, after the infection is settled or after the wax is removed. But if it's due to inner ear damage, over time, we usually wait for the brain to get acclimatized to hearing this tinnitus, and over time, the tinnitus gets softer. Tinnitus is very common, and in most patients, it actually resolves spontaneously, sometimes over days, sometimes over months, sometimes it takes longer than that. If necessary, you can go for tinnitus rehabilitation or tinnitus retraining therapy. I would advise people who are bothered by tinnitus to seek a medical opinion because there are many reasons for tinnitus. Hope this answers your question. Next question, please. Dr. Tan, do you mind answering this question? So this participant has said, I frequently experience itchy outer ear and I tend to use a cotton bud to dig the outer ear to relieve the itch. Is this harmful? I also use Audisol dry ears liquid to spray my ear after washing my hair to remove the water. Is this necessary? Dr. Tan, please.
Hi, thanks for the very popular question. And yeah, I would say that cotton buds are not necessary to dig the ears. Obviously, the itch is quite irritating, but the risk of the cotton bud is that it will push the wax further into the ear. Extreme cases, it has caused the cotton bud to be lodged inside the ear, causing an infection. And even more extreme cases, when somebody knocks your hand, the cotton bud can injure the eardrum. So most importantly, the ear is self-cleaning, so there's really no need to clean the earwax. I think when it's itchy, you can just rub the ear from the outside. In terms of using a liquid to spray your ears after washing your hair, I don't really think it's necessary as well. You can just use a hair dryer to blow dry your ears. And in cases whereby the earwax is really unable to come out, you can see a GP. They can irrigate the ears, and if the GP is unable to clear the earwax as well, I'll be happy to see you to remove the earwax under direct view with a microscope.
Okay, Dr. Tan, next question, please. How much would be the cost of a pair of hearing aids? Excellent question. So hearing aids have a large range, much like buying a handphone. You can buy a handphone for $100 or $2,000 if you buy an iPhone. So for hearing aids, they can range from $2,000 to $10,000. The next question that you may have is then, does the government subsidize hearing aids? As usual, you will need to undergo means testing to determine how much government subsidies you may receive. Government subsidies for hearing aids are also a once-off per person in their life. Sometimes it can be quite a substantial subsidy, and patients may end up paying a couple of $100 instead of a couple of $1,000. So if you think you may be eligible for subsidies, you can come to either the community hearing centers, which there are a few around the island by different hospitals, or to the hospitals themselves for assessment for eligibility for subsidized hearing aids. Hope this answers your question. Next question, please. Dr. Tan, the next question is about wax again. I don't know whether you think this question has been answered before.
I think so, yeah.
Okay, let's finish this question, please. Another question on hearing aids. So this participant says, I paid $3,000 for a pair of hearing aids, and it's not perfect. It is very noisy when you turn it louder to hear clearly. Does SGH have a department to help with purchasing of the right pair of hearing aids with subsidies? Excellent question. So as I mentioned in my talk, clarity is the biggest issue in hearing loss. And it is often not the fault per se of the hearing aid, but because of the disease process. The nerves and the brain actually help in clarity of what you hear. So hearing aids will amplify the frequencies that you do not hear well and make it loud enough so that you can hear all frequencies. But your brain and your nerves need to get used to hearing them again. So the best way to hear clearly from your hearing aids is to wear them for at least 8 hours a day, except when you are sleeping, showering, or swimming. SGH has the department with the hearing center where we do counsel patients for hearing aid purchases, and also do fine-tuning of hearing aids that can purchased in SGH. Hope this answers your question. Next question, please. Okay. Is vertigo one of the cause for ear blockage? Dr. Sim, could you answer this question, please?
Yeah, so vertigo is just but one of the symptoms that you experience. So it is not a diagnosis per se. So vertigo, just for everyone to understand, is a sensation of spinning, of the environment spinning around. So there are, of course, conditions where you will feel vertigo as well as ear blockage at the same time. And this is known as Meniere's disease, but Meniere's disease is not common at all. But yeah, if you do feel any, vertigo, it could also be related to a brain problem. It could be related to a ear problem. So I would suggest, it's very broad. So I would suggest that you see your general practitioner for it, to triage the problem.
Actually, Joyce, can I just interrupt? Because I think in the interest of time, you may want to group the questions a bit better. So I think from my view of the Q&A board, I think there are probably three broad areas of questions. One is tinnitus, which you have kind of covered. Second is giddiness, and the third is of hearing aids. And there are also some very specific questions, and I think it's a bit difficult for us to answer very specific questions in such an open public forum. But is it okay if I just share some of my answers in a broad manner of tinnitus and giddiness?
Sure, please go ahead, Dr. Tan.
Yeah, so I think quite a frequent question which Joyce has also answered is tinnitus. So tinnitus is a very common symptom, and I think especially in the current season of COVID, whereby everyone is isolated at home and not going out, we have seen an increase of influx of patients referred to us for tinnitus. And I would say that it is a very common symptom. Most of the time it is not much cause of concern, but I would warn my patients that some of the red flags or more worrisome symptoms to look out for is if it is one-sided, if it's affecting your mood severely, if you are feeling depressed or having insomnia because you are so affected from your tinnitus, then you definitely need to come and see us early, because patients have become suicidal from having tinnitus. And we'll reassure you, can teach you certain techniques to cope with the tinnitus. Other red flags would be associated symptoms, if it's associated with hearing loss and imbalance. Because my area of expertise is acoustic neuromas, which is these inner ear tumors. They're not common, but because I specialize in this area, so I do see it quite often. And if it's one-sided tinnitus with these associated symptoms, I would advise you to also come and do a hearing test and for you to come and be evaluated by us. So I think the other question I also came across was about pulsatile tinnitus. So some of the participants have said that they can hear their own heartbeat in the ear. So this is also quite a common symptom. In fact, when I was pregnant, there was a very increased blood flow, and I could hear my heartbeat in the middle of the night when I woke up to use the toilet. So most of the time it's because there are some big vessels that cross near the inner ear, and when you do strenuous activity, you can hear the blood flow into your ear. So most of the time it's no big cause of concern, and we usually do recommend doing a CT scan just to look at the structures of the blood vessels in the ear. Very rarely, there's a condition called glomus tumors. So this is a tumor which is very well supplied by blood. And when we look into the ear, we see a very characteristic, what we call a pulsatile mass, and a red mass behind the eardrum. So this is actually easily picked up by just looking into the ear, and this condition would need scans and further management. So with regards to tinnitus, these are some of the things that I would be a bit more concerned of. And otherwise, most of the patients have what we call idiopathic tinnitus, which is we don't really know what the cause is. Some postulate is due to a bit of degeneration of the hearing hair cells. And we need to teach you certain coping strategies, listen to some calming music, like what Joyce said, do exercise, relieving the symptom, and have a good night's rest as well. I think the second part of giddiness, I think giddiness is the expertise of Joyce and Brenda, and I did come across a question that talked about giddiness on head turning, and I think that it would be good to talk a little bit about the most common cause of giddiness that we see, which is BPPV.
Yes, so indeed BPPV, or benign paroxysmal positional vertigo, is the most common cause of vertigo, which is the sensation of spinning. It commonly happens when you lie in bed and sit in bed, or when you tilt your head up to hang your clothes or put your dishes in a shelf, or even when you bend down to tie your shoelaces. Usually it will last for a few seconds. There are many causes for BPPV. There can be no reason at all, idiopathic, like a lot of things in medicine. It can be due to head injury, or it can be due to inflammation of the inner ear. The treatment for BPPV is actually canal repositioning maneuvers, or CRM for short. Some GPs do provide this therapy, or else you may be able to go to the polyclinic doctors as well, or come and see an ENT doctor who may be able to reposition your BPPV crystals, or even a physiotherapist may be able to do it as well. You go to a specialized vestibular physiotherapist, for which we have a very good team in SGH as well. I hope this answers the question. There's one question I just saw. It says, do we go to a GP first to get a referral to SGH, hearing specialist, or must we go to the polyclinic instead? This is an excellent question. So in terms of getting a subsidized referral to SGH ENT, you can go to the polyclinic system, or if you have a CHAS card, you can go to a CHAS-enabled family practitioner or GP clinic, and they will be able to give you a CHAS referral, which is subsidized to any specialist care as well. I think in terms of questions, maybe Shafiq, you don't mind, you just show a few questions and we just run through them quickly.
Sure, Dr. Tang, just give me a moment. Let me share my screen again.
Just saw another question, which is whether bone conduction earphones are recommended. For all earphones, be it headphones, earphones, bone conduction earphones, the loudness of the sound and the duration of time you listen to it is the most important. I do particularly like bone conduction earphones as well, because they do not occlude your ear canal, and so this prevents problems of earwax getting into your headphones and earphones. It also prevents problems of moisture building up in your ear canals as well. So bone conduction earphones can be very good, although the main complaint is that the sound quality is not as good as with the in the canal earphone. But otherwise, in terms of from the medical perspective, they are excellent. Okay. So yes, in answer to this question, in a 55 years old participant who is already using hearing aids, but feels that despite wearing it regularly, it only amplifies the noise, will a cochlear implant be better? I urge you to seek a consultation with your audiologist and your ENT specialist, who may be able to perform further hearing tests with your hearing aids to see if your hearing aids can be further optimized to determine if you are suitable for a cochlear implantation. Next question, please. Next question, please. This participant says, instead of a hearing aid, can you fix a permanent one? Dr. Brenda, do you mind if you answer this question?
Yeah, generally speaking, whether it is, all forms of hearing aid that doesn't require surgical intervention, like the conventional behind the ears one or the in the canal ones, they would require some kind of fitting, and we would advise you to see the audiologist to optimize your experience and to choose the correct hearing aid for you. The ones that I mentioned about in my talk, the bone-anchored hearing aids, those are surgically, there are two components. One is the internal one that is placed surgically, and one that's external, which is the sound processor that you place either where the abutment screw is or where the magnet is. So to answer your question, there is always an external component, whether there is an implant or not. Even for cochlear implants, there's always an internal and an external component. So it's something that you put on in the area just behind your ear.
I think in addition to that, sometimes you may have hearing problems from conductive hearing loss, so like a hole in the eardrum or osticular chain issues. And in these conditions, surgery may be able to improve your hearing such that you no longer require hearing aids. Hope this answers your question. Do you have any question, please?
Joyce, have you spoken about community audiology yet?
No, not yet, actually.
Yeah, maybe you should make a quick mention about it.
So, actually, I did say something about it. Many of the hospitals in Singapore, SGH, NUH, and Changi Hospital, we do have a community outreach branch. Ours is in Johor Bahru, and the community-based audiologists are able to do the hearing test and fit you with hearing aids in the community, and they are actually cheaper than if you have them fitted in SGH. Dr. Tan, do you have anything else to add on to this?
Yeah, I thought about this question is because someone asked whether you always have to see an ENT, come to a polyclinic to see an ENT. So I think MOH has come up with a very good initiative to try and expedite hearing aid prescription for our patients. In the past, the waiting time in SGH to get a hearing aid was extremely long. Patients had to wait for more than a year before they'll get a hearing aid fitting appointment. Thankfully, with our community audiology, which is the audiologist actually sees the patients in the community center rather than in the hospital, we have brought down the waiting time for hearing aid prescription in SGH to about 1 or 2 months. And generally, you keep the more complicated hearing aid cases within SGH, and the more straightforward ones, we let them see the community audiologist. So yeah, you can search online to see whether there's any community audiology available near you. It's not widely available yet, and you do have to see which community centers such as Tiong Bahru or Outram Community Hospital has this service.
Dr. Brenda, do you mind answering the next question? Is there any harm when I just blow air through my nostrils when I close them, when I have frequent blocked ears? Same, please.
So what you're describing actually sounds like a Valsalva maneuver in which you try to pinch your nose, try to blow out and pop your ears. And oftentimes this is helpful in a condition called eustachian tube dysfunction, which is fairly common. And who gets eustachian tube dysfunction? It's usually in patients who have, sensitive nose called allergic rhinitis. So because of their sensitivities, the eustachian tube also gets blocked up and swollen, and therefore they are unable to equalize the pressure in their middle ear, and so you get a blocked sensation in your ear because your ear is in negative pressure. So by doing this, actually, what you're trying to do is you're trying to open up the eustachian tube and to unblock your ears. So I would say, no, there isn't any harm. In fact, it is recommended if you have eustachian tube dysfunction to help to unblock your ears. And a lot of times with just nasal sprays and, frequent Valsalva maneuver, like what you mentioned, it would often help with the blocked ears from eustachian tube dysfunction. A disclaimer though, if your ears are permanently blocked, I would urge you to see a doctor for it, because sometimes it could just not be a simple case of eustachian tube dysfunction. It could be middle ear effusion, for which one will have to look for underlying causes such as nose cancer, which is fairly common in the Chinese population in Singapore.
Thank you, Dr. Sim. Could I have the next question, please? This question is interesting because I think itchy ears, as mentioned by many other patients, is quite common. As whether it could be a side effect of COVID-19 vaccination. Let me hazard an answer. COVID-19 vaccination is a very common target for many of our symptoms. However, flaky skin and ear eczema are fairly common, and unless I know what your skin texture is like before the vaccination, it is very hard to comment on whether the vaccination is causing you to have flaky ear skin. Thank you. Next question, please.
Thanks, Joyce. I think in the interest of time, I mean, it is already 11:40. So I know that, weekends is precious to everyone, including, of course, Joyce, Brenda, and Vanessa, for them to spend time with their family. So I thank you all for, joining us in this educational and informative talk. And I'm glad that everybody enjoyed it. And I'm glad that, everybody found that the information that we gave useful to you. So this talk is actually recorded live and then will be posted on our SGH and YouTube. So I think later Shafiq will give you all the link. So please feel free to go in, listen to the talk, re-listen again. A lot of the questions that you asked are actually addressed by Joyce, Brenda, as well as Vanessa in the talks. So next slide, please. Okay, so maybe I'll take this opportunity to also advertise a little bit for our next talk, which is nose and throat conditions. We have covered a year today, so next one will be the nose and the throat. So please register this day and then register as well for the talks. And I hope to see you again soon. And I hope that we'll give you as much information and educational material for you as well. So thank you everyone. Enjoy yourself. Enjoy the weekend. Thanks Shafiq also for organizing this talk. Thank you.